Hello everybody, and thank you for all attending. My name's Enys Dalmage. I'm a consultant in adolescent forensic psychiatry, and I've been asked to talk to you about PTSD. So when Tony first asked me to talk about this to you guys, I thought there would be money involved. I've done some investigations and there isn't any money involved, but I've had a lifelong dream to be a firefighter, so here I am. I've only been held back so far by my fear of small spaces, large spaces, the colour red, water and fire. But apart from that, yeah, I'm on track. So I'm going to try and talk about a bit about the diagnosis and how it functions, and also about methods of treating PTSD. I've got a short video as well at the end. And I've tried to keep this relatively short because I'm interested in feedback from other people about their experiences and perhaps colleagues that may have gone through similar experiences. So, PTSD, what is it? I did this presentation for a medical student just to try it out because we test everything on our medical students. And she said, well, it was a good presentation, but at no point did you define what PTSD stood for. So I thought, good. So post-traumatic stress disorder. So as the title implies, there's normally some kind of traumatic event that can set off a stress reaction, and that can be a repeated experience for the sufferer. These are the diagnostic criteria. So we've got a re-experiencing of the trauma that's occurred via vivid, intrusive memories, flashbacks to the experience. That's kind of conscious reliving of the experience. And nightmares are pretty common as well. And this can occur through any of the senses. It's not just visual, it can be smells, it can be touch sensations, auditory sensations can be part of that reliving experience. And usually accompanied by a very strong emotional reaction and strong physical sensations too. So, the individual normally experiences a tendency to try and avoid those thoughts, so they will make efforts to avoid the topic or triggers that might start off the thought processes. Memories of the event are also aversive, and people will just try not to think about what's happened to them. They'll often try and avoid the location, so if it was in a particular area, they may make efforts to not go to that area for whatever reason, and any other triggers that might be around that might start off the memory. You also get this state of hypervigilance, which is a kind of generalized anxiety state where people are just on high alert, and you can often pick this up if you drop something nearby, and people will, you know, like cat-like reactions will catch it. So that's a sort of high startle response or high high alert state. So a generalized anxiety may accompany this disorder. You can get memory loss for parts or sometimes all of the event, which triggered the PTSD in the first place. And it's normally of several weeks duration, and we often find a significant impairment of personal, family, social or occupational functioning. So that's the diagnostic criteria laid out as we would use it to make the diagnosis in individuals. This bit at the bottom, I guess, is the most important for most of us. So how is it going to have an impact on our personal lives, our relationships? How is it going to have an impact on how we are with our kids or our friends? And also what impact will it have on our jobs? And if you're in a traumatic profession, talking to the converted, you know, this is particularly salient. So there was some research which I tried to dig out for this presentation but couldn't quite find it, about PTSD in first responders in terms of ambulance drivers and nurses and doctors in ED. And the end result was interesting, which is that PTSD was much more common in the first responders that were actually going out to the scenes of accidents than it was in the ED staff. And the authors concluded that possibly the reason was that if you're in ED, everything's very predictable. You know which bay is which. You know where the bloods are. If you see someone with a gunshot wound or is bleeding out through a RTA or whatever, you ring the surgeon. You know how to get the cross-matched blood. It's all pretty predictable and contained. So however horrible the thing is that's on the gurney, the rest of it, you know what to do. You kind of, you've got your strategy, and it's all very kind of predictable environment. Whereas being a first responder out in the community, you're going to see some horrific things in a completely alien environment with lots and lots of stimulus going on. So it seems to have a kind of more traumatic resonance with people that are actually on the front line, so to speak. So, what else is PTSD? Well, we've talked about this sense of generalised anxiety and a feeling of unease. Physical symptoms can be part of PTSD, so tiredness, headaches, people can get stomach ulcers through stress and not eating properly, and even things like paralysis of limbs can occur. That's not a neurological paralysis, that's a psychological paralysis, but it has the same impact. It means you can't use your arm or your leg or what have you. So you can get some physical symptoms, and often those are the only symptoms. People sometimes will not get any of the obvious nightmares and flashbacks, but they may start experiencing these physical symptoms. So PTSD, it's inevitable if you repeatedly expose anyone to trauma, even if you're Superman or James Bond. And there's been some interesting research on this thing called courage. So the original researchers, the idea was that there may be a certain personality type or a certain gender or age or ethnicity that may be particularly courageous, and this is what the researchers set out to find. And they didn't find that. They found that courage is just it can be present in a 89-year-old Vietnamese lady or a 15-year-old Swiss schoolboy, or it just didn't seem to have any pattern in terms of the individual. But what they did find was everyone's got a certain amount of courage, and once you've exhausted that courage, you're then in a bad state where you're constantly anxious and really not able to cope very well. Some people have got more of that, and some people have got less, but it's finite. So even if you're James Bond, like I said, with this much courage, once it's gone, it's gone. So PTSD it can be hard to spot in others. People can get pretty good at masking the symptoms of stiff upper lip and pretending everything's okay, so it can be difficult to pick up in other people, and it can be hard to spot in yourself too. So as we've talked about with those physical symptoms, it can present in odd ways that you wouldn't immediately anticipate. It is a cause of loss of job, divorce, drug and alcohol problems, and sadly suicide, as we'll go on to discuss, so we need to take it seriously. And it has a lifetime prevalence of about 3.6% in men and 9.7% in women. That's from a study in the States. I don't know why that gender split is there. I suspect it's because the women are better at seeking help, whereas the men are just suffering in silence and not telling anybody. But if you look at New Zealand specifically, according to the World Health Organization, you're looking at about 6.1% across genders, so that's just a New Zealand average. Anybody know who this is?
Shakespeare?
Yeah, spot on. So this is William Shakespeare. And here is a sonnet, so I thought I'd regale you with a bit of Shakespeare, being British as I am. So tell me, sweet Lord, what is it that takes from thee thy stomach, pleasure, and thy golden sleep? Why dost thou bend thine eyes upon the earth, and start so often when thou sitt'st alone? Why hast thou lost the fresh blood in thy cheeks? In thy faint slumbers I by thee have watched, and heard thee murmur tales of iron wars. Thy spirit within thee hath been so at war, and thus hath so bestirred thee in thy sleep, that beads of sweat have stood upon thy brow, and in thy face strange motions have appeared, such as we see when men restrain their breath. Some heavy business hath my lord in hand, and I must know it, or else he loves me not. So there you go, Henry IV. I probably don't need to point this out, I would guess, but lack of eating. Again, appetite's gone, probably some mood problem going on. Anhedonia, we call that psychiatrically, loss of pleasure, not enjoying life. Sleep problems, we talked about nightmares pretty commonly. So this is a description of someone that had been at war, and this is the wife's description of what the chap was like. Lack of eye contact, so self-esteem issues. Starting often when the person is alone, that's the startle reflex we mentioned, the hypervigilance. Why hast thou lost fresh blood in thy cheeks? So pallor. In thy faint slumbers I by thee have watched and heard thee murmur tales of iron wars. Again, that's probably the nightmares going on there. Thy spirit within thee hath been so at war, and thus hath so bestirred thee in thy sleep that beads of sweat have stood upon thy brow. That's an adrenaline response. And in thy face strange motions have appeared, such as we see when men restrain their breath. So this is sort of panic experiences. Some heavy business hath my lord in hand, and I must know it, else he loves me not. So there's your relationship impact of PTSD. Good old Shakespeare. It's a sort of harder reference to get. I don't know if anyone would spot this. So this is a statue of Gilgamesh. And this is probably the first reference that I could find of PTSD. This is from 2100 BC. And Gilgamesh was the king of Uruk in Mesopotamia. And Gilgamesh's friend Enkidu was killed in front of him in a sort of gory fashion. And he then had nightmares and flashbacks to this experience and discussed them. And this is written in the book. So what does Gilgamesh do? Well, instead of seeking help or talking to people, he does the male thing and goes on a big quest. And is seeking out eternal life as a sort of philosophical anxiety, I suppose. And he fails to find eternal life, but the quest itself gives his life meaning. You can imagine the film rights kind of do themselves. And the sort of conclusion is that the fear of death was actually a fear of being meaningless, and he wanted a sort of purpose in life. So there you go, the first account we had of PTSD, and it actually was probably, we think, the oldest ever piece of literature in the world. So the first book ever written covered PTSD, the Epic of Gilgamesh. So there you go. Here's a more modern example. This is a chap called Ronnie McNutt, who was in the newspapers recently. Sad story, a 33-year-old army veteran who suffered with PTSD following active service in Iraq. He'd recently broken up with his girlfriend and he'd been drinking heavily. And Ronnie live streamed his suicide on Facebook at the end of August this year. The clips went viral across platforms, and as tends to happen with these things, fake backstories emerged about this chap, which were, you know, obviously very distressing for his friends and family. And the thinking was that automated software might have been responsible for the spread. And essentially this software will pick up when things are becoming viral phenomena and will sort of latch on and inflame the kind of response, if you like. These bots are interesting, and we think maybe kind of looking to how to destabilize populations or testing Facebook as a platform for its security. But anyway, whichever, the end result was that this story went viral and, as I said, caused a lot of distress for his friends and family. Media coverage of suicide does tend to increase base rates of suicide. So if you get a high-profile suicide, you often then get kind of copycat episodes. So yeah, it can be quite a widespread phenomena. And I'd written this presentation and thought I was done and dusted with it a couple of months ago. And then there was another case which came through the news, which also tragic. So this is a chap called Sam Bull. Sam is on the left there. That's his dad on the right. He was involved in a helicopter crash and survived, but it was a very traumatic experience for him, and he unfortunately committed suicide in October this year. And he'd been working hard to save 4 of the other people in the helicopter, but unfortunately they drowned. So Sam suffered with survivor guilt, which again, frontline people are also prone to at times, and there is an overlap with PTSD and this notion of survivor guilt. Does everyone know what survivor guilt is? That sort of sense that why didn't I succumb? Everyone else, you know, died and I didn't, and why am I worthy, sort of thing. So, yeah. So I thought I'd mention just a little bit about the history of PTSD and how we learnt about it. War, unfortunately, was how this became a thing. So the first descriptions of this PTSD phenomena was shell shock, soldier's heart, combat fatigue and war neurosis. Shell shock being quite literally when shells were going off, they thought that the explosion and the shock wave was causing some kind of brain damage that was causing the condition. And soldier's heart, again, it was thought to be maybe cardiac as well. They weren't quite sure because some of the symptoms were heart racing, palpitations, that kind of thing. So they thought there was maybe a kind of physical origin to it. So in the 1600s, Dr. Johannes Hofer, I hope I'm pronouncing that correctly, coined the term nostalgia in Swiss soldiers, and you can understand why nostalgia might have been an apt term, because these people were constantly looking back to trauma that they'd experienced. And then similar accounts emerged from frontline medics in German, French and Spanish troops. So this thing, nostalgia, was quite a common diagnosis during the US Civil War in 1861. And after the Civil War, Dr. Da Costa coined the term soldier's heart or irritable heart, as I said, because of those physical symptoms. Again, it came to prominence in the 1800s in the US in survivors of railway accidents, which were pretty common in the days before health and safety regulations. And again, railway spine or railway brain indicates that we thought there was a physical sort of skeletal problem that was going on that may be causing some of these symptoms. So along came World War I. And Captain Charles Myers of the Royal Army Medical Corps coined the term shell shock at that point, thinking it was a brain concussion phenomenon. And in World War I, there were 80,000 cases reported in the British Army of this condition of shell shock. Advent of World War II, we then had the more sophisticated description of combat stress reaction. And this was actually the cause of 50% of the military discharges through the course of World War II. And similarly, I think people will know that there were high rates of suicide among returning general infantry from Vietnam. So PTSD became a formally recognised diagnosis in the 1980s. And the subjects that they used to help them form this diagnosis came from partly from Holocaust survivors from Germany and Poland, and also victims of sexual trauma and rape who would report similar symptoms. So they realised that there was this grab bag of people that had nightmares, flashbacks, anxiety, poor sleep, physical symptoms, and they thought, well, there's something in common with this group, that they've got very similar symptoms and have been through just different types of trauma. And as I mentioned, there was a clear overlap established with survivor guilt. So, does PTSD have to be triggered by something major? No, is the short answer. It can be a relatively minor stimulus which can trigger off PTSD. It may be that someone's been repeatedly traumatised in small ways, and then another small trauma comes along and that sets it off. We normally think of survivors of plane crashes or buildings collapsing or whatever it might be as being the obvious victims of PTSD, but it can be repeated trauma over long periods or something relatively minor. It can be a major stimulus but delivered in a minor way. So there was quite a moving account in a UK documentary about a soldier who had control of one of these aerial drone type things, and he had a small screen about that big with a grainy black and white image on it, and his job was to fly this drone and identify enemy combatants. And he'd found a jeep, and in the jeep he was pretty sure there was 4 enemy combatants. So at the opposite moment he pressed a button and down comes the rocket and the jeep is obliterated. So all he's got is this tiny screen like this, and that was all that happened. He pressed a button, puff of smoke, that was it, the jeep was gone. And he had very severe PTSD as a result of that experience, because he knew that his actions had just immediately ended the lives of these 4 individuals and just couldn't process the experience really. Or the obvious one would be a major stimulus, and the flashbulb memory of my lifetime would have been 9/11. Older generations will remember JFK, and that's what we call a flashbulb memory. So a flashbulb memory is something that's so major and so traumatic that it just gets burned into your retina, if you like. So I can recall exactly where I was when I was watching the news and the footage came off of the Twin Towers. I can remember what weather it was like, which people were around me. I was doing a rehab psychiatry job, and the patients and the staff were all crowded around the TV in the lounge area. So that we would call a flashbulb memory. It's so out of the ordinary and so major that it just kind of gets burned into your brain really. So how do you predict it? This was a quote from one of my favourite philosophers, Mike Tyson, also a PTSD sufferer, interestingly. Yeah, and I think it's salutary. It sort of ties in with that John Lennon, life's what happens when you're making other plans sort of thing. Yeah, I think we just have to be humble and say, well, look, any of us could experience this thing at any time, and it's actually reasonably hard to predict when it will occur or how it will manifest itself. But certainly people that are in jobs where they're experiencing traumatic things on a regular basis are vulnerable and need to have insight and be self-aware, I guess. So, no friend of Mike Tyson, but does anyone know who this is? Thank you, Graham. Yeah, this is Freud. Freud had various theories about why PTSD occurs. And Freud said, well, the brain is essentially trying to retrospectively prepare itself for the trauma that happened. Because when the trauma did happen, it was caught off guard and hadn't made preparations and was therefore, badly damaged, and so it retrospectively attempts to prepare itself by being on high alert at all times, sort of hypervigilance. And the flashbacks themselves may represent an internal attempt to habituate the brain to trauma. So habituation is a pretty common CBT technique. So I shouldn't tell you this story, but when I was a junior doctor, I worked in a big shared office with a nurse, and she and I used to play tricks on each other, and she hated wasps. She had a real terrible phobia of wasps. So I used to put pictures of wasps on a desktop. I used to put dead wasps in a drawer. And my crowning moment was I found this giant wasp and teddy bear, and I put it in a chair, and she turned it around, and there it was. Frightened her. And I didn't like spiders, so my desk was just plastered in pictures of spiders that she'd found. She'd put them in my diary, and there'd be this little rubber spiders would fall down on me, and all sorts of horrible things. But so my desk was just plastered in these pictures of spiders, and I was thinking, oh, this is quite annoying. They're all very disturbing images. But there were so many of them that I thought, I can't take all these pictures down. It's ridiculous. And the weird thing was, after about a week, I stopped being afraid of spiders because I was just so used to seeing them. It just became a kind of... And then I also kind of got into gardening around the same time, and you can't hate spiders. If you're into gardening, they're just everywhere. So that's habituation. It's just constant stimulus that kind of eventually your anxiety response kind of goes down and you're okay with them. So don't test me out though, please. It may be that the flashback experiences are part of the brain's attempt to do that, to habituate us through repeated exposure. In evolutionary terms, it's a pretty obvious survival mechanism. If you're in an environment where traumatic things are happening regularly, it's good to be on high alert because you're more likely to survive than others. So there is an evolutionary advantage. And that process of working through the trauma in a non-threatening situation, maybe a sort of method of doing that processing that you just couldn't do at the time when the trauma was happening because it was too live and too difficult and just not a safe place to do it. Yeah, so what's happening to the body? Physiologically, I'm sure Graham could tell you all of this, but we have a stimulus which mirrors the trauma, which may be external. Someone says something, or you see an image on TV, or there's a loud noise, or whatever it might be. Or it could be internal. You get an internal sensation which reminds you of what you've been through. And then we have the amygdala, which is the sort of emotion processing center in the middle of our brains. And that's what's responsible for our fight and flight reaction. The adrenaline kind of gets released, and we go on high alert. You then get a dumping of glucose into the bloodstream. That's one of the things adrenaline does, because it says get ready to run off or attack somebody, so you need plenty of sugar for your muscles. So you get this glucose dumping, cortisol release, which is your stress hormone, which gets you on high alert, and altered blood flow. And so the blood's going to your muscles and away from your stomach, because you don't need to be eating when you're attacking somebody or running off. You just need to be kind of, it's game time. Tachycardia, so your heart starts beating quickly, you start breathing very quickly, you're sweating, your muscles are very irritable and twitchy, so if this happens when you're sitting down, you often get people fidgety and, you know, maybe standing up a little bit. Nausea, because all that blood's gone away from your stomach, so the food that's in there isn't going anywhere, it's just sitting around and being mulched. And pupillary dilatation, so your pupils widen so you can see everything as well as possible and you can kind of be alert. And then you get a slow remission period over minutes, or sometimes it can take hours for that adrenaline level to sort of drop down, the cortisol to drop down. So that would represent a discrete episode, but you can also get this generalized anxiety where you get these ebbs and flows of adrenaline and hyperarousal and hypervigilance. So here's a picture which says the same sort of thing really. We've got saliva flow decreases, so people report dry mouth, pupillary dilatation, fast breathing, food movement slows down and bowel movement slows down, apart from right down the other end when you can often get diarrhea if you're in a very terrifying situation. Blood vessels will change diameter, and you can get a blood pressure increase as the major vessels are dilating. We've got blood vessels in the skin constricting, so you might get chills and sweating, fast heartbeat. The output of digestive enzymes decreases and your muscles become more tense. So these are the adrenal glands, adrenal sitting above the renal, the kidneys which are in there, and that's where your adrenaline is largely coming from. So hopefully you recognise this organ. This is the brain, and there are various bits that I suppose are interesting with PTSD. The frontal lobe, this is where we think personality sits, so this is judgment, decision making, impulse control, processing of, you know, complex situations, executive functioning, so planning of how you might approach a difficult situation. The hippocampus, which is in here, which is memory, so that's when you're getting your flashbacks and your nightmares and you're reliving the event. It's that system's involved. And then the limbic system, which is your emotional, well, a bit higher, which is your emotional processing bit. So the memory is triggering frontal lobe processes of thinking about the trauma, and then you're getting the amygdala response, and then you get the adrenal response and the cortisol, and then you're on high alert really. Yeah. So what? Why do we treat PTSD? Well, it's associated with quite a lot of problems. High blood pressure, high stroke incidents, chronic insomnia, which itself can cause car crashes and, you know, plane crashes if you're a pilot, heart attacks, MIs, obesity, and drug and alcohol problems. And of course suicide we've talked about. Wider than the sort of biology, you've also got things like family breakdown, loss of jobs, car crashes just due to inattention and fatigue, and yeah, as we've mentioned, increased rates of suicide. So what do we do? Well, this biopsychosocial approach is the right answer to any medical student question about psychiatry. They always are programmed to say, I would take a biopsychosocial approach, and that kind of covers all bases and lets us know that you're probably going to pass your attachment. So biopsychosocial, bio being biological, psycho being psychological, and social being social. So you're looking at things quite holistically if you can do. So biological, we do use medication for PTSD. There's a whole range of antidepressants, so that's sertraline, fluoxetine, citalopram. Those are serotonin reuptake inhibitors. Propranolol, which is a beta blocker. Prazosin, which is an alpha blocker, so these are anti-anxiety. And then benzodiazepines, you'll have heard of things like Valium and that kind of drug. So we can use medication for them. Psychological, CBT I mentioned before, that's the cognitive behavioural therapy. This is quite an appealing therapy, I think, to most people. It's got a really good evidence base because it's very easy to do research on it. It's very practical. So the typical PTSD sufferer would be a businessman who comes in and says, look, I've got this thing and I just want you to fix it. I don't want any airy-fairy Freudian stuff. I don't want to tell you about my childhood. I just want you to fix me so I can go back to work. So I had a chap that I was working with in the UK, and he had a brain tumour, and The tumour had been removed successfully, and he had to go for serial MRI scans of his head. And back in those days, you had to keep your head absolutely still for the scan to work. If you didn't, then it was ruined and they had to start again. So it's about a half an hour procedure, the scan. And the means of keeping his head still was to put a plastic face mask on him, which fixed his head in one position, right? So he's got a couple of nose holes he can breathe through his nose, but he can't move his head otherwise. And the nurse says to him, here's a button, and if you're feeling anxious at any point during the scan, press the button and we'll pause it, and we can have a cup of tea and have a break and then come back and we'll do the rest. And he says, great. So the nurse goes off and promptly goes to the toilet and meets a friend and doesn't come back in for about 20 minutes. And this chap is in with his face mask on, and he suddenly starts to think to himself, what if I'm sick? If I'm sick, I've got this mask on, it's got these two small nose holes, I may choke to death on my vomit, and this is pretty awful. So he's stuck in this mask. So he starts pressing the button and nobody comes, and his anxiety level just goes up and up and up until at the end of it he's a gibbering wreck. So he comes and sees me in clinic, and what happened after that experience was he'd gone off to stay in a cottage with his wife. And the owner of the cottage, this is a terrible fire safety strategy, but the owner of the cottage said, we've had a few burglaries, I'm going to lock the cottage door at night, so you're not going to be able to get out. There's a bathroom in the cottage, you'll be fine. In the morning, I'll come and unlock it at 8 o'clock, and then you can go. And the wife thinks, oh, it's a bit weird, but fine, okay, off we go to bed. And the husband starts freaking out because he thinks, I can't get out, I can't escape, and starts feeling very claustrophobic and very anxious. The next thing that happens to him is he's driving to work, and as he's driving to work, he's stuck in a long line of traffic, and he suddenly starts to think, I've got cars in front of me, I've got cars behind me, I've got cars, I can't get out. There's cars next to me, and the panic again starts to raise. So awful experience for this guy, and again, successful businessman, just wanted this to be fixed really. So we did CBT with him, and we gave him homework projects, and he was just a dream patient. He would laminate his homework and bring it into me, and always attended on time. He was great, and sure enough, he got better pretty quickly with that approach. So it's a very effective treatment, CBT. And it again, asks you to sort of test out your hypotheses, and you give them little homework projects to do, and they can build up their tolerance to the sort of noxious stimulus. EMDR is interesting. I will talk about that in a second. That's eye movement desensitization and reprocessing. You can see why we call it EMDR. And computer games, which is very close to my heart, is another method of treating PTSD. So you can visualize and put somebody actually back in the situation without them actually being in it. And war would be a very obvious one. There's so many war computer games out there these days. And we're also now using VR headsets again to really entrench somebody in the reality of it. And again, that's things like graded exposure, habituation, testing out. We've got a video which we'll talk about that as well. So that's your psychological bit, and the social bit, marital therapy, very important, and some of that has a psychoeducation component, so it's about understanding what your partner's going through, and realising that this isn't complete breakdown, but is something that's probably treatable. Support groups, very helpful for people that have been through similar things, and vocational support, again within mental health services, fortunately we're pretty good at looking after each other and supporting each other, and all organisations where you're on the front line should have similar mechanisms for support. Benefits, again, of course it's important if you're off work for any period of time, and ACC claims. And yeah, as I mentioned, psychoeducation of the network that's around the individual so that everyone's on the same page. So CBT, best evidence base in terms of psychological therapies, and one of the techniques is exposure therapy, so you can ask the patient to imagine and sort of you can get them to relive the experience in front of you, or do more indirect things like drawing and writing about the experience, or go with them to visit the place where the traumatic memory is linked, or again meet with people that might trigger the response. As I mentioned, we do use VR headsets, and you often will start small, so you'll start with a very, very innocuous stimulus and then build up gradually rather than flooding someone with a sort of very traumatic thing straight away. We have a process of desensitization, and that tends to lead to a reduction in that stress hormone, the cortisol, and a reduction in the adrenaline response, and eventual habituation. And I've already talked about my spider example, so there we go, I was ahead of myself. So what would Freud do? Freud was a brilliant chap, and a lot of the theories are still around and as important now as they've ever been, really. And Freud would look at reality testing, so consider your appraisal of what you actually did in that situation. Often people are carrying around a lot of guilt or blame, and so it's about reflecting on that, really, and just beginning to help the person reframe the experience. So a common question would be, how reasonable are you being on yourself in the situation? Do you really think you could have done more? Do you really think things could have turned out differently, and so on? EMDR, yeah, fascinating. So this is the eye movement desensitization and reprocessing. So essentially what you do is you have your patient sitting there and you get them to focus on a task. And the typical one, we used to use a watch on a chain or a pendulum of some description, but now we've got these very fancy light bars which are about this long, and I've got a light which will just move from one side to the other, a bit like Knight Rider in the old days, people remember that? So it's a big light bar like this, and they have to keep their head still, but their eyes will track the movement of the bar, and during that tracking you will talk to them about the experience that's causing them anxiety. So you don't have to use a light bar. So for kids that aren't very good at keeping their head still, you can just tap on either side of their leg or either side of their arm. So that's another way of doing alternative brain side stimulus kind of thing. The therapist will talk to the patient about the trauma, and you aim for a reduction in anxiety and some sort of processing of the trauma whilst they're engaged in the eye movement task. We're not quite sure how it works, but it seems to change the brain's neural pathways by essentially associating the traumatic memory with new non-threatening information, namely the sort of eye movement process. So yeah, magic. We're not quite sure how it works, but it seems to. And it may be that it's actually the reflection on the memories that's the important bit of the therapy rather than the expensive light bar. But there you go. And final, I think my final slide, animal therapy. This is my favourite because I work with kids and the kids love animals. There's reasonable evidence with canine assisted therapy and equine assisted therapy. So we had a young person on the ward who had a very complex PTSD. She'd been traumatised in early life, and she had a real affinity for horses. It was the one thing that would help her really calm down. I will pause there and show you the video that I've got, and then I don't know how we're doing for time, but hopefully we've got time for a few questions at the end. So it's not a very long clip, this, but I thought it was reasonably germane.
Well, in the 30 years I was on the department, this ended up being the big one. It just filled me up, overwhelmed me.
Ward Redwood is a captain with the Grand Prairie Fire Department. Post-traumatic stress disorder nearly cost him a 30-year career. That's why he's decided to tell his story, starting with the night of the crash.
It was a dynamic sight. The pulling on scene, there was a truck upside down in the middle of the road, and it was running. And it's a diesel truck, so it's saying they're running and just adds to things.
The pickup had collided with the car, sending it into the ditch. 2 teenagers were dead. A third boy was seriously injured in the passenger seat. There was no sign of the pickup driver. Redwood was using a thermal imaging camera to search the scene.
As I'm moving it, a white image appears on the camera, and it was just like, I still remember it. It was just like this whole adrenaline thing went through me, and it was just like, my brain said, that's a deer, but I knew it was another boy.
Redwood ran to the boy's body lying in the brush off the road, but found no pulse.
I know I'm worked up. Adrenaline's just pumping through me. And I know that I still got a job to do, right? I found one. I'm like, I got to keep looking. And it was within 3-4 seconds. I got another white signature on the camera.
4 boys, 2 15-year-olds and 2 16-year-olds, died in that crash on October 22nd, 2011. Grand Prairie rallied behind the family and friends of the teens, but Redwood tried to navigate the aftermath alone.
You know, back in the day, that's all we did is with any trauma event like that is just pushed it down, tucked it away, didn't think about it, didn't talk about it.
His marriage fell apart after the crash. He became a single dad. Life moved quickly and the crash faded to the background. That is, until a nightmare brought it roaring back 5 years later.
The nightmare was wicked. It was really threw me. It was like these two boys' faces looking up at me from down below, and I was leaning over them and I had my flashlight. Kind of felt like something was wrong, but couldn't put a finger on it.
After the nightmare, he froze up twice on the job while using the thermal imaging camera. It felt like he was caught in quicksand. A psychologist told him it was workplace stress and too much coffee. But things only got worse from there. Sleepless nights, short attention span, memory problems.
I was treading water a little bit. You know, I wasn't really doing a good front crawl. Some of my get up and go had gone. My enjoyment of things was starting to disappear a little bit.
Redwood finally got a PTSD diagnosis, and soon after the therapist said he was going to have to tackle the big one.
I know what the big one is. I just don't want to deal with it, right?
Any stress response there, whether you're pointing the camera?
Therapist Steve Buckle in Grand Prairie used prolonged exposure therapy. Redwood told the story of the crash over and over again, at times holding the camera he used to find the bodies.
Take the TIC camera, go up to Fire Ground Command. And
The therapy was grueling, recording the sessions and listening back to them. He was warned his symptoms would get worse before they got better, and they did.
that part that concerned me for quite some time is, you know, a big one, right? The feeling of love had totally gone away, and I had no feeling of love for quite some time, like years.
On the 7th anniversary of the crash, another nightmare. Except this time, instead of the two boys, it's his two daughters looking up at him.
And this one throws a switch in there. It just, oh. That one's a hard one to tell anybody about. Certainly can't tell my girls, but I suck it up and I get back in there and we start getting at it, and you know,
From the night of the crash.
No, we're back.
I get up to go and grab the medic, and then I'm like, whoa! I'm like, whoa, Steve! Steve! I said, I froze up. And he's like, what? I said, I froze up on scene. And the memory came back to me that I froze up. That same feeling, that quicksand feeling, I'd actually did it on scene. And I'd repressed it. I didn't even know. I had no memory of it whatsoever. And all of a sudden it came back. I was having a little trouble, and I went and got some help.
He could feel a change in himself. He was going back to the fire hall to have coffee with the crew, but he knew things had really turned a corner when he dropped his youngest daughter off at her mom's just 2 weeks later.
Go to give her a hug before I leave, and I have this full-on feeling of love for her, which I haven't had for years. And it freaked me out. It was like, I didn't say anything to her because she didn't know that I didn't have it. I never told them that I didn't have it.
Redwood went back to the fire hall part-time, but he had a choice to make: return to full service at the risk of more trauma, or retire on his own terms.
I'm happy, I'm healthy, I'm really enjoying life. To me, it was just time. And hopefully we're smarter in the future and look after ourselves better. I know we do.
His last official day as a firefighter was on November 20th, but he hopes his story will be an example for all first responders, especially the thousands struggling with PTSD.
It was emotionally draining and it was physically draining. Every part of me hurt sometimes coming out of those, but it gets better. You just got to put in that hard work. I hope they hear that and ask for help.
Okay, so thanks to YouTube for that clip. It was a very generous sufferer who really wants his message to be heard, and Yeah, so thank you very much. Are there any questions that anyone's got, or any that have come through via the phone? And I'll do my best to answer them. I think we're hoping to put up some information about areas or methods of getting help for this kind of difficulty. The obvious first port of call would be the GP. GPs are great at being the gateways to lots of other services, so they can certainly put you in touch with the right people. And there is an emergency number for TIHICA, which is our crisis team, and if you're in real dire straits, they're again a good group to ring and get support from. And they provide 24-hour a day, 365 days a year support, and you'll get a crisis nurse who will be on the front line, but then there's also doctors as well who can see you out of hours. So yeah, those are the best methods to access support.
Enys, we just had a question come in. Someone would love to hear your thoughts on vicarious trauma and accumulated stress trauma.
Yeah, I mean, I think I would go back to the point I was making at the sort of midway through, that the trauma doesn't have to be directly experienced. It doesn't have to be what we would call major trauma, in the sense of you don't actually have to have been there. So yeah, vicarious trauma is a not uncommon experience for healthcare workers to talk about, because we're dealing with young people that have been through terrible experiences, and often carrying those around is a sort of heavy thing to do. And yeah, it's a genuine cause of burnout within health services, and I'm sure within your professions as well, that you'll have loved ones that you may relate to and talk about the sort of work experiences that you've had. So yeah, a genuine problem. I think vicarious trauma tends to present in slightly different ways, so that's more commonly manifested in psychological avenues, so that could be generalized anxiety, panic attacks, that kind of thing. Whereas PTSD can be a bit more covert and a bit more hidden and clandestine and sort of harder to pin down. But yeah, a not uncommon problem within again, frontline staff, unfortunately.
Why do you think people are so strange about this issue? I mean, I don't know if it's everybody, but I think firefighters are not very comfortable talking about it. Why that is?
Yeah, I mean, I suppose there's some fairly obvious theories around in terms of people feeling that they should be able to cope with these kind of things, and that it's not macho or professionally fitting to talk about it. I think what has helped is some very high profile and famous people coming forward and talking about their experiences with PTSD. So Mike Tyson would be one example, but those kind of figures will enable other people, I think, to feel more empowered to discuss it. But I mean, I think there is still a stigma attached to mental health problems in a way that there clearly isn't with physical problems. If you'd broken your leg, sorry Graham, broken your ankle, something similar, you clearly wouldn't pretend that you hadn't and suck it up and just carry on. You'd go and get help. But even in the 21st century, we're still dealing with a fair amount of stigma, and so our colleges of psychiatry will do various campaigns to try and destigmatise mental health and put it on an equal footing really with physical health. But the brain is a very complex organ in a way that the kidney is perhaps not quite as complex. We kind of understand mostly how the kidney works, but the brain's got more fundamental connections than there are particles in the universe. It's 200 billion or something. It's a very complex machine, and it can break down in lots of interesting ways. But the important thing is that there are avenues of support and help out there which are accessible if people can make the first step of saying, I need help, I'm struggling.
I've got a question actually. If you feel that someone around you is actually suffering from PTSD, what's your best approach?
Yeah, I mean, I guess it depends on how open that person is about their symptoms. If what they're presenting with is nightmares and they're saying, oh, I'm struggling, I'm feeling stressed at the moment, but I'll be okay, you might need to do a bit of psychoeducation with them. So again, there are avenues out there. GPs again are a pretty good source for garnering resources. And the internet, it can be a wonderful thing. So the Royal College website will have pamphlets, guidelines, information about mental disorders. The key bit, though, I think, is insight and recognition and just naming what's going on. And people will suffer in silence for a long time until it gets to a point where suddenly they can't do something. They literally can't go to work, and then that's often a sort of crisis point where they'll recognise there's a problem. You know, the most sympathetic thing I think you can do is just listen and try to help them understand as well that actually there may be an issue that's going on there, and that it may be having an impact on the relationship or the relationship with the kids. The firefighter that was talking in the video clip there, I thought was very interesting with his description of his relationship with his daughters, that he literally hadn't felt love for them, and for that to be an experience that you have as a parent is unthinkable for most of us to imagine that, but it happened to that guy, and it was again a kind of consequence that he was on high alert and just didn't have the brain power to do the emotional processing stuff with his daughters. So I think when you start picking up warning signs like that, it's about, you know, gently supporting your partner to understand that what's going on is treatable, and but a serious problem with some serious consequences if it's not dealt with.
So is there a time frame in which it gets less likely that you'll be able to resolve PTSD from the traumatic event?
Yeah, no, not as such. I mean, it's very, there's a lot of individual variation. So the Vietnam War vets were a sort of good example of this, that some people, the symptoms manifested straight away. Some people it took, you know, 6 months, some people it took years before they started experiencing symptoms. The good news is, I think, you know, once you're symptomatic, there's stuff there that we can treat, and we can treat it relatively quickly and simply with that biopsychosocial approach. So yeah, the issue with PTSD is people naming it and coming forward and seeking help. Once they've done that, the rest is gravy. Do you know what I mean? It's pretty straightforward from that point. It's just the issue of getting help in the first place, and that's the killer. You know, so the stories that we talked about with Sam Bull and Ronnie McNutt back in the presentation, they just weren't receiving appropriate help really, and it just built up to a point where it was all consuming, and unfortunately they could no longer tolerate it. So yeah, the issue is getting help. Once you've got someone with the symptoms in front of you, as a therapist, it's pretty straightforward to manage that with them.
Got a question in from the text. What do you do if your GP doesn't recognise PTSD?
Change your GP. I mean, the number of GPs out there that would not recognise it, I would hope is relatively small, and it's been a pretty well established diagnosis for a long enough time now that people should be picking it up pretty quickly. Yeah, my only advice would be change the GP, get a different opinion from somebody else that's perhaps a bit better informed in terms of mental health problems. But I mean, yeah, as I said, I would hope that the number of GPs that are actually not picking it up is relatively small. The challenge, of course, is that it can present in odd and interesting ways. So, you know, tiredness is a very common thing that people go to GP practices with. That can have any number of causes, from anemia to malignancy to, you know, some strange infectious disease to COVID to PTSD. So, you know, there are lots of potential causes, and they may misdiagnose it. But I think once someone's got the pretty classic symptoms, the GPs should really be picking it up. But as I said, I would be seeking a second opinion, really. I think if you're pretty clear that that's what's going on and the GP's just not acting on it, then you need to get a second view, really. Certainly I wouldn't sit on it.
A question from me, Enys, could you just repeat it back to so people can hear? What's your sense of how soluble it is as a problem? I mean, the chap in the video ended up having to quit being a firefighter. That's not a very attractive prospect for a lot of people, I suppose. No, and I think, I mean, that again. So just to repeat your question, you were talking about the resolution likelihood with this kind of disorder, and you know, I suppose whether it always has that trajectory of people having to leave work completely, or whether you can resolve it and maintain your position. Again, I think it is very individualised. It does depend on that person's circumstances. I think that chap had left it quite a long time before he did manage to get appropriate help.
and perhaps if that help had been more available earlier, the outcome might have been different. Similarly, maybe there were other reasons for why he decided to retire. I think certainly for people that are young and want to maintain their position and aren't even thinking about retirement, I would hope the outcomes are pretty good. I mean, in terms of mental disorders, it is very amenable to CBT, and we often combine that with medication. As I said, most of the patients that I've seen that we've managed with PTSD will get a good degree of resolution to the point where it's no longer impairing their general functioning, daily living skills, and employment prospects and education prospects as well. So I would encourage people to access help as early as they possibly can do. I think organisations are getting more and more sophisticated in terms of how they manage their workforce, because of course they want to retain staff and not lose them. So early interventions are becoming more fashionable, which is a positive thing. And again, we're recognising, as part of what we're doing here, is making sure it's on people's minds and we're conscious of it. So yeah, I think early access and engagement in something like CBT or EMDR, plus some judicious use of medication, and I would be optimistic about resolution in most cases.
So, what's your feeling on some of the newer treatments like microdosing and all that sort of stuff?
Yes, so I have to be careful what I say here. There's a fair amount of controversy around microdosing. I mean, when I was a trainee, we used a fair amount of ketamine on patients that were in for eye surgery and just had a bit of local anaesthesia, and that was what ketamine did, and we didn't really think of it. It was a horse tranquilizer, that's another use of it, and we didn't think of it beyond that. Now there is good evidence that it's very useful in depression. We've got, as you mentioned, sort of microdosing studies which look at drugs like LSD. There was a whole slew of research in the States about LSD in the 60s and 70s with pretty rubbish outcomes. You know, it was discredited really as a treatment, but now it's kind of re-emerging. What I would say about it is the evidence base isn't there yet, but the scientific position is we don't know. Which is the most frequent scientific position you'll find, is we just don't know. But in contrast to things like CBT or sertraline medications, whatever, where we can say actually there's a good evidence base for this, at the moment with things like microdosing we don't have that. Things change very quickly though in terms of research. So if you'd asked me a year ago about ketamine, I'd have said we don't know. Early trials look interesting, but we're not sure. And now it's an established treatment with depression. So yeah, things can change pretty quickly in terms of research. Notably the COVID vaccine, which, you know, fingers crossed, we're hoping will be a goer. So yeah, I think the jury's out at the moment, but yeah, it looks interesting. Mm.
Tony's question and your answer partially answered mine as well. So your views on the importance of like an informal debrief after a moderate to serious incident at the station? Sorry.
Yeah, so Graham was asking about the sort of merits of debriefs after incidents. I mean, I feel kind of quite passionately about this, and really I think debriefs should happen after all incidents, even if they're seemingly relatively minor, given what we talked about, that the stimulus doesn't have to be major, it can be minor things that have happened. So I would be supportive of yeah, that kind of debrief process for all traumatic events. So if you look at what we're trying to do in hospitals after restraints, where young people have had to have physical support and restraint, we're trying to do debriefs after all of those so that people can talk about it. We get the same stiff upper lip approach in hospitals, so the support workers will say, oh, I just got punched in the face, it's fine, I'm going to carry on, I'm okay to work. Whereas actually they need to sit down and reflect a little bit on what happened and what emotions were associated with it, and how it, you know, how they might have actually felt their life was threatened in the heat of the moment. So yeah, it's important not to overlook those sort of things. And I think part of the reason I was so passionate about it was when I was a junior doctor, our average work hours were sort of, you know, 99, 100 hours a week. And we had this doctor's mess, and we'd all congregate in the doctor's mess at the end of the shift, and we'd say, oh, this dreadful shift, and 3 cardiac arrests, and we couldn't find the venflons, and there was a really difficult intubation. And we thought it was just a joint moaning session when we, you know, sort of be complaining about various conditions, but actually it was therapy. We were talking through our experiences and processing them and thinking about them and reflecting on them with other people. So yeah, that was a kind of informal example, but in working life these days, I think it really should form part of any incident, really. I think you need all right, if you're rescuing a cat from a tree, fair dues, you probably don't need, but you know, anything where there's a degree of, you know, trauma and challenge, I think it's helpful to have a debrief. And you know, I've personally been surprised with what's coming out with even minor incidents where you've thought, oh, I really didn't see it from that angle, or I didn't know that was a trigger for you about, you know, what happened before or what have you. So yeah, I'm a big fan of the debrief, really. I think it's pretty crucial part of a healthy service.
What would you suggest, like for officers or for anyone who hears someone express something that sounds like this, you know, what should they actually do about it?
Yeah, so Tony, you're asking what staff members should do if they pick up symptoms which looked like PTSD or could fit into the diagnosis. I think the key thing is I certainly wouldn't try and approach it in a group setting. I think an individual sit down with the person in question is probably the best initial approach. And you know, the approach that we tend to take in clinics is again just sort of open questions. So how are you doing at the moment? How are you finding work? How's home life going? So some nice broad open questions. You may get a bit of a brick wall with people saying everything's fine, stop asking me these weird questions, but just be persistent, keep at it and keep coming back with more and more open questions, and eventually you can narrow it down to saying, you know, you seem quite on edge at the moment. Is that you know, something that's an issue for you? One of the things that we frequently do when asking questions is normalising. So this is sort of helping destigmatise things. So often with young people, I'll say, a lot of young people that I work with mention hearing voices. Is that something that happens to you? So rather than saying, are you hearing voices? The response might be, are you implying I'm mad? You know, what a weird question. You do a bit of normalising and saying, look, this is a common thing that people talk to us about. Similarly with suicide, with child abuse, you know, those kind of things. We'll do normalising and say, look, a lot of people mention this has happened to them. Is it something that's happened to you? So yeah, I would try and kind of open in that kind of way if you can do. And yeah, again, if there's a particular staff member that engages with that person very well, maybe have a chat with them and get them to do that, to have that conversation with them. It's difficult, especially if you know, you're not used to asking those sort of questions, but that shouldn't put you off doing it. It's because the cost of missing it, as we've said, is pretty major. All right. Well, listen, thank you very much, folks. Thanks for your patience and for listening to me waffle on a favourite topic of mine. And my contact details are on there, so if anyone does have any further questions, I'm happy to answer them via email. Okay, thank you.
Thank you so much.
Pleasure.